Hi guys, next up we're going to talk about sarcoidosis, and I'm going to begin this topic in an unconventional fashion by first discussing a mnemonic by the name of sarcoid, where alphabet S would be for the symmetrical hilar lymphadenopathy present in these cases. The hilar lymphadenopathy can explain the extrinsic compression of the airways, and therefore dyspnea on exertion or dyspnea at rest can be explained in these cases. In fact, the compression of the airways from outside will also explain why on spirometry report in these patients in the initial phases, obstructive pattern can be seen. Though this disease in the late phases will cause lung fibrosis and therefore restrictive pattern will occur, but in the early phases of the disease, because of the enlarged lymph nodes and the compression of the airways, obstructive pattern can be present on spirometry as well. And that means that spirometry cannot be used as a test for confirmation or diagnosis of this condition, because initial phase the obstructive pattern can be present and subsequently we can be having a mixed pattern as well because of the pulmonary fibrosis that will set in. Alphabet S can also be used to remember the main treatment for this condition, that is steroids. And before I talk about A, I would like to jump on to C, that is hypercalcemia. Now why that's important is because you see in our body vitamin D is produced by kidney. Our proximal tubules of the kidney have an enzyme by the name of 1-alpha hydroxylase, which will produce 1,25-dihydroxycholecalciferol. Now the big deal is that in sarcoidosis, we have non-caseating granulomas. These granulomas would also be having the same enzyme 1-alpha hydroxylase, which will cause synthesis of vitamin D3, and therefore hypercalcemia and hypercalciuria can be present in these cases. When we will give steroids, we will not only have resolution of sarcoidosis, but once the granulomas are going to resolve, even the hypercalcemia will respond to the steroids. So one of the important statements that I'm not writing down at the moment, but a must know statement for this topic to be remembered by you is steroid responsive hypercalcemia. Even in the electrolytes video, I've spoken about it. Steroid responsive hypercalcemia, sarcoidosis. When we give prednisolone, we have resolution of the granulomas, and therefore the hypercalcemia and the hypercalciuria will also show a gradual resolution. Alphabet A would be due to lung damage. The ACE levels are found to be elevated, though ACE levels are elevated even in diabetes mellitus and even in silicosis. But ACE levels elevation in sarcoidosis do give credibility to diagnosis. Alphabet R is again a very peculiarity of this disease, that though I'm talking about bad things like renal damage due to hypercalcemia, in about 50% of the cases, we might be able to demonstrate remission. So I can say that in half cases of sarcoidosis, we will be having a good prognosis. The disease will burn out, or there would be remission in 50% of the cases in the next couple of years. Alphabet O would be standing for the ocular involvement. There are two of them. One ocular involvement that we usually see in these patients is going to be in the form of uveitis, and in fact this iridocyclitis or the uveitis component will again help in diagnosis of this condition, especially when we are in a doubt, especially if a patient is having hilar lymphadenopathy. Now that can be due to lymphomas also, and the hilar lymphadenopathy could be seen with sarcoidosis also. You see, when you do a lymph node biopsy, in the periphery of a lymphoma also non-caseating granulomas can be present. So a pathologist will be in a dilemma, because I said non-caseating granulomas are seen in sarcoidosis, but they are seen in the periphery of a lymphoma as well. So the additional finding that would help us know that, okay, we're not dealing with a lymphoma, but with sarcoidosis would be an ocular involvement in the form of iridocyclitis or uveitis. I would be for interstitial lung disease, so there would be pulmonary fibrosis and a reduced diffusion capacity of the lung for carbon monoxide in the late phases of the disease. And alphabet D would be for the dermatological involvement. The derma involvement in these patients, I'll show you images for the same in a while, but at the moment these could be purplish painful nodules on the shin of a patient. So just like you're aware of pyoderma gangrenosum on the shin of an inflammatory bowel disease patient, today in sarcoidosis, I want you to remember a lesion on the shin. That would be erythema nodosum. This would be a purplish elevated lesion, painful to touch. And another dermat manifestation is very classical, because this would be seen on the face and on the cheeks and on the nose of a patient. So that's why the term used is lupus pernio. And you can see the importance, because traditionally we read about lupus vulgaris, that's skin TB, when the lupus pernio would be a skin manifestation of sarcoidosis. Having said this, we'll now focus on the specifics of the disease. The first specific detail to be remembered for this multisystemic disorder, in which minimum of at least 2 or more than 2 organ involvement has to be demonstrated. I'll make a list before you what are the common organs which are involved, but we need to demonstrate at least 2 or more organs having non-caseating granulomas. And we read about non-caseating granulomas not only with respect to sarcoidosis. In fact, we read it even in inflammatory bowel disease. If you have listened to the video of ulcerative colitis and Crohn's, there I've spoken about it. Then we also need to remember occupational lung disease that can be having non-causating granulomas, that is berylliosis, that would be seen with respect to aerospace industry. And then would be hypersensitivity pneumonitis, which is a type 4 hypersensitivity and is also written as extrinsic allergic alveolitis. I repeat once again, HP is also written as extrinsic allergic alveolitis. That would be a type 4 hypersensitivity reaction. So now you're aware of 4 conditions where non-causating granulomas can be present. And I did tell you about the fact that granulomas are documented to be present in periphery of a lymphoma as well. So we need to be cautious before we make a diagnosis of sarcoidosis. And the best way for diagnosis of this condition would either be a transbronchial lung biopsy, or we might have to go for an endobronchial ultrasound guided biopsy. That's after all a lung biopsy only. And therefore we'll be able to make a final diagnosis on a combination of clinical findings and laboratory findings as well. And the laboratory finding has to reveal presence of non-causating granulomas, though all these conditions obviously have to be excluded. Now, what are the common organs which are involved in this condition? Then overall, the commonest organ involved is obviously the lung. But after the lung, if he's not going to give that in the options, then it's either going to be answered as liver or it's going to be answered as skin. For the liver involvement, all I can say is that Harrison states that 50% of cases of sarcoidosis can be having a liver involvement that can be demonstrated on a liver biopsy where granulomas would be present. Though liver involvement can be silent as well, because see, liver has a big reserve. So even if granulomas are present in the liver, there is a possibility that symptoms may not be present, or the bilirubin levels of the patient may be normal. They might be only slight elevations of serum alkaline phosphatase, or they might be slight elevations of SGOT, SGPT, but that classical jaundice may not be present. And then as far as the skin involvement is concerned, that would be about 33% of cases, where as I've explained, the two manifestations could be in the form of erythema nodosum or lupus pernio. Then the opposite, the question can be asked as which is the least common organ to be involved. So there's a table given in Harrison where the percentage of organs that they've evaluated in various case series are given, and heart involvement is given in only 2% cases, but lung involvement is given in majority of cases. Then another question that can mention is which organs are unlikely to be involved or rarely involved in this condition. So your answers would be given as breast, then is testis, and then is the ovary. So do take a mental note of the fact that when we are talking about organs which are commonly involved, I mean this initial data that I'm showing you at the moment is from the perspective of what are the common organs that are involved, and then I've described about organs which may or may not be involved. That would be breast, testis, and ovary. And in fact, one more I would like to mention is stomach. Then as far as the chances of death are concerned, now look at the stark data that I'm telling you. On one hand, I was saying the disease can exhibit a remission. In 50% of cases, there can be a remission in next few years. It is described in the textbook in the first few lines itself as a self-limited, non-life-threatening inflammatory multi-system disorder, where we need to demonstrate at least 2 or more than 2 organ involvement. So that's okay. And the contrasting part is I'm saying patient can die as well. Well, the reason for patient dying would be mainly due to lung involvement. And what I mean by lung involvement would be development of pulmonary fibrosis. If this is not handled, even pulmonary artery hypertension could be occurring in these cases as well. And apart from lung involvement, other reason why these patients can be dying is due to damage to the liver or damage to the eyes in these patients in the long run. And if he says sudden death, then the answer would not be given as lung involvement or respiratory failure. If we say sudden death, then because heart can be involved in this condition, the non-causating granulomas can be involving the conduction system of the heart or could be damaging the myocardium. The damage to the myocardium can explain why tachyarrhythmias can be developing in these patients as well. And in case the conduction system is involved, we could be having heart blocks. So it is cardiac involvement that can explain sudden death in these patients. But in contrast, if it doesn't use the word sudden and just says routinely what is the leading cause of death with respect to patients with sarcoidosis, your answer would be respiratory failure. That's because of the pulmonary fibrosis component that will set in. Initially, you have mediastinal lymphadenopathy. You have a hilar lymphadenopathy, which is made famous by that eggshell calcification question. You see, eggshell calcification can be seen both in silicosis as well as sarcoidosis. So that's not a very characteristic feature for diagnosis. Overall, I can say for diagnosis of this condition, we need to demonstrate multiple organ involvement, at least 2, and then we need to do a biopsy. It can be a liver biopsy, it can be a lung biopsy, but he says that without a biopsy, the diagnosis of this condition cannot be made. I'll also be teaching you subsequently what are the ways in which If biopsy is inconclusive, like if you did a biopsy but it's turning out to be negative, then what are the ways by which the diagnosis of sarcoidosis can be made? And that would be important from MCQ perspective. But in majority of cases, he's going to ask it in simple words, what's the best way for diagnosis? Your answer would be transbronchial lung biopsy. If there are pulmonary infiltrates, I'll do a transbronchial lung biopsy. If there is a mediastinal lymphadenopathy, hilar lymphadenopathy, then I can go in for an endobronchial ultrasound guided lung biopsy, and therefore the diagnosis of this condition can be made. Coming to the pathophysiology of the disease, you will read that the incidence of sarcoidosis is higher in healthcare workers. Why that is so is not given in the textbook, but there could be possible environmental exposures that could be, or environmental factors that could be contributing to it. Well, one of the environmental factors, especially with respect to hospital environment, that I would like to mention is Mycobacterium tuberculosis, considering high incidence of TB in our country. There's an antigen by the name of MCAT-G. The second antigen which has been incriminated in causing development of sarcoidosis is with respect to this bacteria by the name of Propionibacterium acnes. Now these antigens would be processed by APC. So this octopus that is shown here symbolically is the representation of antigen presenting cells. These antigen presenting cells are now gonna present these antigens to the lymph nodes where the security system is present. And inside the security system, we are having the CD4 cells, which are called as helper cells. And once they are gonna respond to this antigen, that is MCAT-G or the antigen of Propionibacterium acnes, it's gonna produce two things. One, it's going to produce gamma interferon, and second, it's going to produce interleukin-2. Now, gamma interferon is the trigger which is ultimately responsible for granuloma formation. You know that from your pathology classes. And interleukin-2 would be now responsible for CD4 proliferation. And therefore, these pink cells that you're seeing in the inferior diagrams are basically the representation of CD4 cells which are exhibiting a proliferation. Well, what are those blue cells? Those blue cells that are shown here, the basophilic ones, are macrophages. And these macrophages, the security system is busy processing those antigens which were presented by the antigen presenting cells. Now, these macrophages will unite with one another to form a multinucleated giant cell. So in this image on the right hand side, you can see that the macrophages have united together to develop a giant cell which is shown in blue, that is basophilic. And inside this, you can see some inclusions as well. One of the inclusions that you can see, and I'm highlighting at the moment, this inclusion is more of star-shaped. This is a eosinophilic intracytoplasmic inclusion inside the giant cell in non-caseating granuloma of sarcoidosis. And it is also shown in this histopathology slide and is referred to as asteroid bodies. So, well, what are asteroid bodies? They are eosinophilic intracytoplasmic inclusions inside those giant cells which are present in the macrophages, which are formed from conglomeration of macrophages in the non-caseating granuloma. And the second thing that you're noticing at the moment, where I'll just put a green arrow to highlight, is these blue aggregations. These blue aggregations are the ones which are also shown here. So one, you can see the cell once again, you can see the multinucleated giant cell, you can see the multiple nuclei, and you can see these blue inclusions as well. Well, what are these blue inclusions? These are again intracytoplasmic inclusions. They're basophilic because they are calcifications and they are referred to as Schaumann bodies. So from the pathology perspective, you guys are aware of Schaumann bodies and asteroid bodies. Asteroid bodies, though we read about sporotrichosis also we read asteroid bodies, but today we're talking about them in sarcoidosis inside those giant cells in non-caseating granulomas, which are eosinophilic, and Schaumann bodies are going to be basophilic because of the calcium deposition. That would be the pathophysiology component. I'll just repeat that once again. The antigens we're talking about is Propionibacterium acnes and Mycobacterium tuberculosis, MCAT-G antigen. And well, they are gonna be grabbed on by the antigen presenting cells, which are gonna send them to the security system for evaluation, that is in the lymph nodes. There the CD4 cells are gonna produce large amounts of gamma interferon and interleukin-2, and the two are responsible then for this cellular response, which you can see here, which creates these giant cells and granuloma formation. The granuloma also possesses an enzyme by the name of 1-alpha hydroxylase, which is important for synthesis of 1,25-dihydroxycholecalciferol, which is why hypercalcemia can be seen in cases of sarcoidosis. And the moment you treat it with steroids, you have a resolution of sarcoidosis, and therefore the MCQ will say steroid responsive hypercalcemia seen in. The answer would be the topic of interest. Before I mention the clinical features, I would also like to mention regarding the clinical spectrum of the disease. it can be asymptomatic. I mean, a large number of cases of sarcoidosis, about 33% of these cases can be asymptomatic as well. So, well, how would they be detected? Well, they would be detected on a routine chest X-ray. Now, this is very far-fetched in India because, a person in India would not be undergoing an annual medical checkup. But unlike in America, where medical insurance is important, there is a possibility that a person, a young lady, she's 30 years of age, and her company has made it mandatory to get an annual medical checkup done for her medical insurance, and on an X-ray there might be hilar lymphadenopathy that might be noticed, though the lady might be asymptomatic at that particular point of time. Once the lymph nodes will become bigger, they're going to press on the airway, so she will become symptomatic, but a disease might be detected earlier on a routine screening with a chest X-ray, or the X-ray might have been done for some other reason, like maybe she suffered from symptoms suggestive of COVID, and that's where the hilar lymphadenopathy was picked up. Another spectrum of the disease that should be remembered is Lofgren syndrome. For Lofgren syndrome, I would like you to pick up two alphabets in the end, that is EN, to take care of the dermatological manifestation, which would be seen on the shin of these patients, that is erythema nodosum. And along with this, there would be a hilar lymphadenopathy, which would be visible on a chest X-ray as well, though these patients may be initially asymptomatic as well. Now, Lofgren syndrome in some cases may not be having erythema nodosum. So, EN minus here basically means that erythema nodosum may not be present in some cases of Lofgren syndrome. Well, in these patients, there might be a presentation of then periarticular arthritis. So, that's the peculiarity that the examiner wants to hear or wants you to know, that even arthritis can be a presentation with respect to sarcoidosis. That's a periarticular arthritis, and along with that, hilar lymphadenopathy would be present. So 1/3 cases asymptomatic, some can be having Lofgren syndrome. Well, the good news with respect to Lofgren syndrome would be that in 90% of cases of Lofgren syndrome, where there were two things present, erythema nodosum with hilar lymphadenopathy, there could be a possibility of a remission as well in the next couple of years. So that is good news. Once again, I said couple of cases can be asymptomatic. That is why I was saying self-limiting disorder with a limited amount of damage that it can cause. Some patients will obviously suffer, so I'll describe those manifestations also, but in a large number of cases, even if the manifestations will occur, there can be a development of remission in about, like in Lofgren syndrome, we're talking about remission, and overall I'm saying that even in those cases which will become symptomatic, remission would be seen. We'll now focus on those cases which are going to be symptomatic. So the case is usually going to be described for a young female. She's in her late 30s. Let me say she's 35 years of age. And the reason why she's come to us is because she's having this non-productive cough, and she's also becoming breathless on exertion. Initially, we might think that there is a cardiovascular reason for the same, but soon we'll realize on doing an X-ray that since she is having a hilar lymphadenopathy, which is causing an extrinsic compression of the airways, and that is why the breathlessness is developing. And if the patient comes to us late, the breathlessness might be severe enough to be present at rest as well. Along with this, there would be constitutional symptoms that would be described in the form of fatigue and low-grade fever, evening rise of temperature, night sweats, and even weight loss. And because of this, even a seasoned physician might be tempted to think that he is dealing with the case of pulmonary tuberculosis, and he will soon realize his folly, because the lymph nodes are going to continue to increase in size and are not going to respond to antitubercular treatment. And what the physician missed here was, one, the skin manifestations in this condition, and second, the ocular manifestations as well. The skin manifestations would be two. One that you can see, though I had mentioned about them earlier also, would be these purplish nodules on the shin, which would be discomforting to touch. That would be erythema nodosum. And we read about erythema marginatum in rheumatic fever, but we read about erythema nodosum with respect to sarcoidosis. And then these would be these purplish lesions for which we can do a biopsy as well of the skin. And in fact, that would again give credibility to diagnosis, because it's not necessary that we have to do a lung biopsy. We can do a skin biopsy as well in case the skin lesions are present. And these purplish lesions that are present would be referred to as lupus pernio. You're aware of lupus vulgaris, that is skin TB, but lupus pernio would be involving the cheeks and the face of the patient and the nose of the patient as well. So what the physician was missing in this particular case is the skin involvement, which would have given credibility to diagnosis as sarcoidosis. If you're not having a skin involvement, how would you be able to identify? The hilar lymphadenopathy will be associated with uveitis. In some cases, they can be dry eye as well, that is Sika manifestations or Sika syndrome manifestations could be described as well. Coming to the liver involvement in this condition, in majority of cases, serum bilirubin will be perfectly normal. SGOT, SGPT would also be normal, and the only derangement that we'll get would be serum alkaline phosphatase, implying an obstructive pattern of liver disease. See, liver biopsy can detect granulomas in about 50% of the cases, but that's in a retrospective that we have identified that 50% of cases of sarcoidosis would be having a liver biopsy positive. But routinely, we do not do a liver biopsy. We do a lung biopsy, a endobronchial or a transbronchial lung biopsy for diagnosis of this condition. Then coming to the hematological manifestations, we will notice that the leukocyte count or the TLC of these patients would be lesser. The lymphocyte count is also lesser. Well, the rationale behind why that is so is because of the sequestration of the lymphocytes in the granulomas, the sequestration of lymphocytes in the lymph nodes, and therefore we are able to see leukopenia and lymphopenia in these patients along with development of anemia as well. So that would be the hemat profile that can be asked to you in the exam. Like in rheumatoid arthritis, he loves to ask about anemia of chronic disease. Here he would love to ask you regarding the lymphopenia and the leukopenia component, and do not mix it up with bronchoalveolar lavage findings of this condition that I'll be describing subsequently, because when we do a BAL in these patients, we are able to demonstrate a BAL lymphocytosis. I repeat my statement once again, in the blood, it would be a lymphopenia as well as a leukopenia. But in bronchoalveolar lavage, it would be a lymphocytosis, and the CD4-CD8 ratio would be value more than 3.5. The data has to be remembered, guys, because this is a common source of error in multiple choice questions, that in the blood it is lymphopenia and in the bronchoalveolar lavage it is a lymphocytosis. Coming to point number 7, I've spoken much about it in the earlier part also. This condition is an example of a steroid responsive hypercalcemia, and apart from hypercalcemia, there can even be hypercalciuria. And because of this hypercalciuria, there can be a possibility of damage to the tubules in the kidney as well as a possibility of development of stones in these patients because of elevated serum calcium values. Now, point number 8 is again something that is to be remembered because neurological manifestations would be present. So let's look at the neurological manifestations of this disease, that is neurosarcoidosis. And the first one to be remembered is lymphocytic meningitis. The non-caseating granulomas can even involve the hypothalamus and can damage the pituitary as well. So they can be manifestations of polyuria polydipsia, that is central diabetes insipidus. Another cranial nerve that can be involved in this condition is optic nerve. And because of the optic neuritis component, there can be a big possibility of misdiagnosing neurosarcoidosis with multiple sclerosis. You see, we read about optic neuritis in multiple sclerosis as well. But then in MS or multiple sclerosis, there are going to be evidence with respect to MRI, like we read about black hole lesions on T1 weighted images, we read about Dawson fingers on T2 weighted images. So as such, multiple sclerosis, which would be a Scandinavian or a Nordic woman who would be having Utta phenomenon, where neurological symptoms would be coming on heat exposure, like she's doing workout or she's having fever or she's taking a hot bath, or there is increase of body temperature, and that's when neurological symptoms would be developing, is called as Utta phenomenon. I've spoken about it in neurology, and this condition usually also causes optic nerve involvement. So the main point why you need to remember the optic neuritis component is because optic nerve involvement can be seen with respect to sarcoidosis and can be seen with respect to multiple sclerosis as well. The differentiation can be made on the basis of an MRI, where I described black holes for T1 weighted images in multiple sclerosis and presence of Dawson fingers as well. Then if he says what is the common cranial nerve which is involved in these patients of sarcoidosis, then because of bilateral parotid enlargement and through the parotid glands the seventh nerve is traversing, we can also be reading about bilateral seventh nerve palsy. We traditionally read about bilateral seventh nerve palsy with respect to Guillain-Barré syndrome, but apart from GBS, even sarcoidosis is to be remembered as an example of lower motor neuron involvement of the seventh nerve. So from the neurology perspective, two data are worth remembering at the moment. The commonest cranial nerve which is involved in sarcoidosis should be answered as the seventh nerve, though even the second nerve can be involved, and the differentiation from multiple sclerosis can be done. There are three conditions where we read about bilateral seventh nerve palsy, that is Guillain-Barré syndrome, sarcoidosis, and then we also read it in motor neuron disease, amyotrophic lateral sclerosis as well. But in amyotrophic lateral sclerosis, if I get into that, it will change the entire dimension. So I would suggest you to read about amyotrophic lateral sclerosis or motor neuron disease from the neurology spectrum. And amyotrophic lateral sclerosis can be having both lower motor as well as upper motor features. So this that I'm describing at the moment is a lower motor bilateral seventh nerve palsy in GBS sarcoidosis, and even in ALS, in amyotrophic lateral sclerosis, we could be having lower motor involvement of the seventh nerve as well. Agreed, the disease is in the brain, but if the nucleus of the nerve is involved or if the nerve is involved, it's a lower motor manifestation. As far as the ninth involvement is concerned, that would be cardiac. So you could be having non-caseating granulomas involving the heart. So there could be a development of myocardial damage that could explain congestive heart failures. And then these could be sites, wherever these non-caseating granulomas are present, those would be sites for abnormal current generation that can contribute to arrhythmias. In case the non-caseating granulomas affect the conduction system of the heart, heart blocks can occur. High-grade heart blocks can contribute to bradycardia and possible syncope as well. And to identify that there is a cardiac involvement, there are a couple of imaging that is available now. We can do a endomyocardial biopsy as well, but the problem with endomyocardial biopsy is it can miss the lesion. So nowadays what we'll be doing is either a cardiac MRI or a PET scan, and these are two investigations which are used for identification of extrapulmonary sarcoidosis. Just like we read about extrapulmonary TB, I'm describing extrapulmonary sarcoidosis can be picked up on basis of either a PET scan or a cardiac MRI based on whatever findings or whichever facilities which are available. The last feature that I'll be describing for these patients can be severe muscle pain as well as joint pain as well. And I would once again like to draw your attention to the fact that in Lofgren syndrome, I mentioned sometimes erythema nodosum may not be present, and it is arthritis that could be present in the case as well. So this is the spectrum of disease manifestations with respect to symptomatic patients. 1/3 of cases can be symptomatic and couple of them might develop the disease but then will go into a remission. Overall, I can say the disease in 50% of cases overall can exhibit a remission over a couple of years, or I can say the disease tends to burn down, and overall in those patients it would be having a relatively better prognosis. Coming to the workup of these patients, we shall be doing a chest X-ray, and they can ask you about the various stages of disease evolution. Initially, the patient would be having a hilar lymphadenopathy, which would be bilaterally symmetrical, and along with this, there could be enlargement of the right paratracheal group of lymph nodes as well. When you will attend a radiologist session, they'll call this as 1, 2, 3 sign, but I'm keeping it traditional data of hilar lymphadenopathy with or without right paratracheal lymphadenopathy. In stage 2, we will be having two things present. That would be enlarged lymph nodes as well as lung infiltrates would now be visible, and majority of cases of sarcoidosis would be having lung infiltrates in the upper lobes. I'll mention a list of those conditions where lung infiltrates in upper lobes are present. TB is one such condition, but we'll make a list in a while. Then as far as stage 3 of the disease progression is concerned, now the disease will primarily cause lung parenchymal involvement, so we will mainly get bilateral lung infiltrates. And then in stage 4, there would be progressive pulmonary fibrosis. And this pulmonary fibrosis will cause total lung capacity to become lesser, residual volume to be lesser, and DLCO, the diffusion capacity of the lung for carbon monoxide, to be lesser as well. Like I said, this disease has a predilection for upper lobe infiltrates. So let's make a list of those conditions where we traditionally read about upper lobe infiltrates. TB is obviously one of them, but the commonest occupational lung disease in India, that is silicosis, also causes upper lobe infiltrates. Then is HP, hypersensitivity pneumonitis, that's called as extrinsic allergic alveolitis. Then is Langerhans cell histiocytosis, which is also called as Christian disease. This would be causing, this is where you have those CD1A positive histiocytes, which have electron microscopy finding of Birbeck granules. Then tuberculosis, obviously, and pneumocystis jirovecii are a list of certain conditions where we can be having upper lobe infiltrates over and above the topic of interest, that is sarcoidosis. Let's just quickly revise the 4 stages as well. The X-ray images can be given to you for bilateral hilar lymphadenopathy with or without right paratracheal lymph node involvement. Then is adenopathy with infiltrates, then infiltrate, and ultimately a pulmonary fibrosis. So you will notice that the question will be in the stem of the question itself. There would be description for the radiological findings as well. The initial test that we do in these patients is a chest X-ray, though if he talks about a CT chest, then the pulmonary infiltrates that are present would also be mentioned from a radiology perspective as galaxy sign. From the spirometry perspective, I have said this earlier also, you might be noticing obstructive pattern present. In the initial part of the disease, when the hilar mediastal lymph nodes are causing compression of the airways from outside, obstructive pattern could be described in the form of FEV1, FAC ratio less than 0.7. This would be seen in almost 50% of the cases due to airway stenosis. And when I'm writing this word airway stenosis, it is very clear that this is an extrinsic compression on the airways. It's the lymph nodes which are pressing on the airways from outside, because of which this airway stenosis is present. In fact, some cases can be having airway hyperreactivity as well to methacholine challenge test, which we traditionally read with respect to bronchial asthma. In the same cases, in the later phases of the disease, because pulmonary fibrosis will set in, so that is when DLCO will be lesser, and then even the spirometric parameters will change. You can see that sarcoidosis is one disorder where obstructive pattern, restrictive pattern, or mixed pattern can be described as well. And in the later part, obviously, because there's a pulmonary fibrosis component, that is why I've said DLCO will be less. For identification of extra pulmonary sarcoidosis, the test that I'm going to run is a PET scan. Instead of PET scan, we can be doing a MRI as well. And then instead of MRI, in earlier times, we used to read about a gallium-67 scan. It is not that gallium-67 scan cannot be done, but he says currently it's a PET scan that is recommended for diagnosis of extra pulmonary sarcoidosis. And what are those conditions where what are those organs where extra pulmonary sarcoidosis can be demonstrated? It can be in the liver, in the spleen, it can be in the skin. In fact, all organs of the body can be involved, and even heart can be involved in this condition, and that could be resulting in even possible fatal arrhythmias, which are one of the reasons why these patients can die suddenly. Though if it doesn't mention sudden death, then I've explained to you the usual cause of death would be answered as respiratory failure due to a lung involvement. Then a very interesting test that can be described in MCQs is ACE levels. The reason why the ACE levels are elevated in these patients is because of the parenchymal damage to the lung. Well, ACE levels are not very specific for diagnosis of sarcoidosis, because mild elevation can be seen of ACE levels even with the diabetes mellitus. So it's not a very specific disease. Mild elevations can be seen even with diabetes mellitus. Up to more than 50% elevation above the upper limit can be seen with respect to SGLT. By SGLT, I mean that conditions where you are getting a substantial involvement would be sarcoidosis, or substantial increase in the values of ACE levels would be seen in S, that would be sarcoidosis, G, that would be Gaucher's disease, L would be for leprosy, and then T would be for tuberculosis as well as thyrotoxicosis. This is just a quick mnemonic to make you again remember that SGLT is a mnemonic to remember conditions where you can be having a significant increase in ACE levels. What I mean by significant increase in mathematical terms is at least a 50% increase above the upper limit. Suppose upper limit values is 1. So I'm saying values more than 1.5 times above the normal is where the gross elevations can be seen, or substantial elevations can be seen. So this is a list of those conditions where ACE levels are elevated. So alone ACE levels would never help in diagnosis of this condition. The investigational choice for this condition would be answered as bronchoscopy with biopsy, as I've explained to you. If it is stage 1 or if it is stage 2, then we can go in with endobronchial biopsy. This would be an endobronchial ultrasound guided biopsy. On the other hand, if it is stage 3, then in those circumstances, we'll be going in for a transbronchial biopsy. Most MCQs will not use terms like transbronchial or endobronchial. They'll just talk about bronchoscopy with biopsy for diagnosis of this condition. Though I did mention stage-wise that in the early phase of the disease, that is stage 1 and stage 2, it would be endobronchial ultrasound guided biopsy. And in the later phase of the disease, it would be a transbronchial biopsy that would be done. Another test that can be used for diagnosis of this condition is bronchoalveolar lavage. In bronchoalveolar lavage, the finding that will be described will mainly be in the form of lymphocytosis. I've already sensitized you to this earlier, that we get lymphopenia in this condition in the blood, but in the BAL, he will mention about lymphocytosis. And another thing that would be mentioned for BAL would be a CD4-CD8 ratio of value more than 3.5. Traditionally, guys, we read about CD4-CD8 ratio with HIV. We read about CD4-CD8 ratio with respect to AIDS. No, it's normally affected in AIDS because of CD4 cells being affected. But here we talk about CD4-CD8 ratio in bronchoalveolar lavage. So do make a note of that. BAL lymphocytosis and BAL CD4-CD8 count are tests which are to be used for diagnosis in those circumstances where biopsy is turning out to be inconclusive. So if there's no evidence of any alternative diagnosis and the organ biopsy is turning out to be negative, then let's make a note of the three tests that must be done, and all three should be positive for diagnosis of this condition. Well, the first one would be serum ACE levels. Like earlier I was saying, serum ACE levels can be showing a mild elevation with diabetes. Up to 50% normal values can be elevated in SGLT, that was sarcoidosis, Gaucher's, leprosy and tuberculosis. Now I'm saying the serum ACE levels should be elevated to at least 2 times of whatever are the normal values. And it is not that alone serum ACE levels would be diagnostic. Two more investigations need to be done. The second investigation that must be used for evidence is bronchoalveolar lavage lymphocytosis. This has been shown to be more accurate as compared to CD4 CD8 ratio, the value of which has been described to be more than 3.5. The first arrow for that more than is to give credibility to the fact that BAL lymphocytosis is more accurate as compared to CD4 CD8, and the value 3.5 is for the ratio per se. The third investigation that should be done to prove that we are dealing with a case of sarcoidosis is a gallium 67 scan. So we'll be doing or seeing a panda sign and a lambda sign. This panda sign is because like the panda will be having blackening around their eyes. Similarly, the panda sign here is due to the involvement of the lacrimal glands, and the lambda sign is because of the involvement of the lymph nodes in the chest. Like I was saying, there's a mediastal lymphadenopathy, hilar lymphadenopathy, and there's a right paratracheal lymph nodes. So that looks like a lambda, the involvement there of the hilar lymph nodes as well as the right paratracheal group of lymph node. I mean, we just drawn a symbol here to represent the mediastal lymph node as well as the right paratracheal lymph node enlargement, and all three of these should be demonstrated to be together in those cases where there would be a negative biopsy finding but there is no alternative diagnosis present. Once we have confirmed the diagnosis on the basis of point number 7 or the current slide, then it would be time for treatment of this condition. Coming to the treatment of this condition, we'll be using steroids. If it is only anterior eye involvement or local skin involvement or cuff present, then we can be using topical steroids. However, if there is a neurosarcoidosis present in the form of lymphocytic meningitis or cranial nerve involvements occurring in this place or cardiac involvement producing symptoms, or there is a hypercalcemia, then the mainstay treatment would be steroid, that is systemic steroid prednisone. And anyway, if it's a multi-system disorder, symptoms with multiple organs getting involved, again we'll have to give prednisone and taper the patient to the lowest possible dose, usually up to 10 milligrams, so that we can get a clinical remission. Alternative drugs which can be used for management of this condition over and above the usage of steroids, because they're bound to produce toxicity, would be molecules like hydroxychloroquine, methotrexate, azathioprine, and infliximab. Infliximab are described even in inflammatory bowel disease, in rheumatoid arthritis management, and even in management of ankylosing spondylitis. So yes, biologicals do play a role, but initial management or a majority of cases, either the disease will show a remission by itself or will show a good response to prednisone. Next up is inflammatory myopathies, where are described diseases like dermatomyositis, polymyositis, antisynthetase syndrome, and inclusion body myositis. And before I do that, I would also like to draw your attention to a couple of histopathological data here as well. This green marking that I've done around an individual muscle fiber would be per se endomyosium. In contrast, the blue marking that I'll be doing subsequently, this that I'm doing at the moment, that is around a bundle of multiple myofibrils, would be called as perimyosium. Now, why it is important for you to know this baseline information is because lots of time in those questions where clinical findings in rheumat can be, a bit mind-boggling because there's so many of those findings, and there could be trouble with respect to identifying a particular rheumat disorder only on clinical grounds, then histopathology finding will come in handy, because every time you will read literature of dermatomyositis, you're always going to come across this terminology, perimyosial inflammation, perimyosial atrophy. So I'm just putting a star mark to here to say that out of these four, dermatomyositis is one of the most important topics which is asked. And in case you're not able to pick it up on clinical grounds, then MRI guided biopsy. Why MRI? Because it will help us pick up those focal areas of inflammation, and once we are able to increase our diagnostic yield, it's always better. And then the biopsy finding will always say perimyosial atrophy, perimyosial inflammation, as you can see in the slide, and the slide will be discussed subsequently as well. Also, I would like to draw your attention to the fact that in all of rheumatic conditions, well, we always find gender female obviously leading as compared to men. I mean, the incidence of SLE is more in women as compared to men. Same is the data that we read with respect to scleroderma as well. But for even for dermatomyositis, even for polymyositis, but inclusion body myositis is different in a sense that one, the incidence would be more in men as compared to women. Usually, the disease is seen after 50 years of age, and then you will also notice that in all varieties of myopathies, I'll always be focusing on proximal weakness being more common as compared to distal weakness. But this is one such, I would say, inflammatory myopathy where both proximal as well as distal muscle involvement is documented equally. Traditionally, it is always proximal muscle involvement. Proximal would mean like muscles around the hip joint. So patient would have difficulty in climbing stairs or getting up from a chair or getting up from a toilet seat, or like elevating, raising your hand above the level of the shoulder when you're trying to comb your hair or when you're trying to put clothes on a string. I mean, that's where the proximal muscles are used. So in majority of inflammatory myopathies, proximal muscle weakness will be given to be more as compared to distal, but here proximal and distal muscle involvement will be given equally. And we can also point out which are the common group of muscles that would be given in this particular case. So the distal muscles that would be described in this particular case would be finger flexors. Along with finger flexors, even wrist flexors can be involved, and in the lower extremities it would be mainly the muscles which would be moving the hip joint as well as moving the knee joint. And one of the important ones that is moving the knee joint and should be remembered is vastus medialis. So I mean, these are the group of muscles which are usually involved in this particular condition. And since rheumat is all about antibodies, so the name of the antibody is of paramount importance, and the name of the antibody to be remembered here is anti-CN1A antibody, responsible for inclusion body myositis. And then over and above this, association also has to be remembered. That would be with the leukemia. The leukemia which is usually associated should be remembered as a granular lymphocytic leukemia. In fact, all of them, like when I'll be describing dermatomyositis, I'll be talking about association with malignancy, association with myocarditis. Those are like a little less remembered data, but then it's worth its weight in MCQs. So granular lymphocytic leukemia, then S-Sjogren syndrome and Sika syndrome are associations which have to be remembered with respect to inclusion body myositis. And I decided to first speak about this topic primarily because of the issues of one, the gender swap that occurred in this particular case, plus the involvement of distal muscles and proximal muscles both being involved equally, in contrast to dermatomyositis where the focus will mainly be on proximal muscle involvement. Now, what is dermatomyositis? So as far as the theory behind it goes, this is mediated by beta interferon. It's a beta interferon mediated microvasculopathy. And this microvasculopathy has a tendency to involve, the blood vessels which are involved are primarily of two areas. That would be of the skin. That is why those dermat manifestations would be present. And then microvasculopathy will also involve the muscles. So let's look at those classical features. And I'm very sure you are aware of this from your dermatology as well. I'll write down the standard data. Symmetrical proximal muscle weakness will be one of the primary complaints of these patients. What I mean by symmetrical proximal muscle weakness is difficulty in standing up from a sitting position or squatting position. In fact, in some MCQs, they might even say the word Gower sign. They're not writing it because Gower sign is traditionally described in textbooks only for Duchenne's muscular dystrophy. But in some MCQs in the previous exam of NEET PG, they did mention the word Gower sign even for dermatomyositis. So I'll write it and I raise it because technically this is not appropriate. Gower sign is classically described for Duchenne's muscular dystrophy. But because this was given in the exam, I just mentioned it here. Gower sign simply means you will ask the patient to sit down or sit cross-legged or squat on the floor. And then you'll ask the patient to stand up. Now, you and me, our hip joint muscles are in top shape, so we can get up. But a person with dermatomyositis, because hip joint muscles are weak, therefore difficulty in standing up. So probably the thought process of the examiner was only to say that the patient is having difficulty in standing up from a sitting or a squatting position, and therefore there's a symmetrical proximal muscle weakness. And that does not mean that there would not be a distal weakness. It does happen. Distal weakness would be like a difficulty in turning a doorknob. or difficult, or like accelerating a bike, or let me say the turning on the key while trying to, I mean, nowadays cars can be, the ignition would be with a button, but in earlier times you used to have to insert a key and then turn the ignition. So difficulty in turning on the ignition key of a car or a bike are like manifestations with respect to distal weakness seen in a patient. Now, as far as the skin microvasculopathy is concerned, the classical manifestations, because majority of these MCQs would be image based, and you are aware of this from dermatology as well. So what you can pick up is the rash, which is around the upper eyelid. Predominantly, it's present in the lower eyelid also, but I would like to specifically highlight the rash on the upper eyelid, which would, casually look like as if somebody has put on some makeup, and that would be a heliotrope rash. It's a violet discoloration. It's a violaceous discoloration as described in the textbooks. Though in a dark-skinned individual, that violaceous discoloration may not appear so, but in the classical image-based questions where they might show a white patient to you, the violaceous discoloration or purplish discoloration of the upper eyelid might be well picked up. Another feature that is usually neglected but can be written in MCQs is presence of swelling around the eyes, that is periorbital edema. I mean, traditionally we read about periorbital edema with heart failure or periorbital edema with nephrotic syndrome or cirrhosis, but even with the microvasculopathy involving the skin, periorbital edema is present. Then on the hands of these patients, you will be able to notice on the knuckles mainly Gottron papules. And it is not necessary that only we might be able to see papules. Sometimes there might only be a rash present on the interphalangeal joints. They may not be papules. So lots of time you will notice the word Gottron sign written. Now, all I can say is they're playing around with English here. I mean, papule is a palpable finding, but if Gottron papules, which are usually seen on the knuckles and on the interphalangeal joint, if they are not palpable, then he might use the word Gottron sign. And this Gottron sign can be seen even in the elbows of a patient. So it's not that the rash would be limited only on the hands. It can be on the elbows as well. And why I'm pointing out is because you see, every time you come across a rash on the elbows, you are also thinking in terms of another disorder, that is dermatitis herpetiformis. But in dermatitis herpetiformis, there would always be a past history of celiac sprue, or I mean, the patient is a known case of celiac sprue, or history suggestive of celiac sprue would be given in a question. There could be association with antibodies related to celiac sprue, like TTG antibody, tissue transglutaminase antibody, that could be described. So I just wanted to highlight this fact that every time they give you a lesion on the elbows, don't straight away think in terms of Gottron sign, and do keep a watch for dermatitis herpetiformis as well. And to resolve the problem, you can do a test. The test would be anti-epidermal transglutaminase antibody that helps you pick up dermatitis herpetiformis. Plus, you can do a skin biopsy as well, where IgA deposits can be seen in the skin. Then another manifestation that is seen on the skin of patients or dermatomyositis would be a shawl sign. As you can see on the back, the erythematous rash that is present. And along with this, the rash could also be present on the V of the neck. So traditionally, we see in the V of the neck Cassell's necklace of pellagra. And traditionally in medicine MCQs, if they're ever, there's some miscellaneous facts, so I'm just writing it separately, that in a medicine MCQ, if they are talking about pellagra, then one disease that you must always keep in your mind is carcinoid syndrome. Now, I have described carcinoid tumor, carcinoid syndrome with pheochromocytoma, so I would like you to go and listen there. But the main point is carcinoid syndrome will be a tumor which will be causing misuse of tryptophan to produce excess of serotonin, and tryptophan is required for niacin synthesis also. If you're going to divert all the tryptophan towards the synthesis of excess of serotonin, then availability for niacin synthesis will be lesser, and that would explain why the pellagra manifestations can occur in carcinoid syndrome. And why I spoke about it is because the lesion for pellagra would be again seen on the neck of a person, and here we're talking about a V sign, which would be erythematous rash that would be encountered in patients with dermatomyositis. Over and above this, there can be association with interstitial lung disease, so that's important. Spirometric findings of total lung capacity being lesser, residual volume being lesser, DLC or diffusion capacity of the lung for carbon monoxide being lesser could also be described in a question. Patients with dermatomyositis also have increased risk of development of myocarditis, and the bad news is that this lady will be having a higher incidence of chances of development of malignancy. Though malignancy risk is increased in both dermatomyositis and polymyositis, On a comparison basis, the malignancy risk is more with dermatomyositis as compared to polymyositis. So I put two arrows here and I'll be putting a single arrow for polymyositis. So both are going to be increasing the risk for malignancy. Usually it's going to be ovarian cancer in this woman. And then as far as the diagnosis of this condition is concerned, in the workup initially, we'll be doing tests like CPK-MM. Like you are aware, CPK-MB is useful for diagnosis of reinfarction. In this case, CPK-MM could be showing up to 50 times elevation above the baseline normal values. Now I will be writing a couple of antibodies, which are the main pickup points. So you have to remember anti-melanoma differentiation agent MDA5. Then there's another one by the name of anti-TIF. So a bit of work that you need to do with respect to the antibodies which are present here, as is the standard norm in RUMAT. Majority of questions of RUMAT will mention the name of the antibody to make it easier for you. So there are other ones also like anti-MI2. So traditionally, MI2 normally we read Mission Impossible, right? That's the Tom Cruise movie. So this is MI2 here, anti-MI2 antibody. Another one worth remembering is anti-NXP. So the names of these antibodies are the ones which I would like you to remember. And then we will like to do a MRI guided biopsy. The logic behind doing a MRI guided biopsy is only to pick up those areas of myositis or muscle edema where the chances of getting a positive finding on biopsy will increase. And when we do this MRI guided biopsy, the main finding that would be present in these patients and would be usually given in those integrated kind of questions would be one, perifascicular. I want you to now look at this. I want you to compare the size. I'll just use an alternative color here. I want you to compare the size of the I would say the muscle fibers here as compared to muscle fibers in the periphery, and you can notice a perimysial atrophy present, and you can also see this blue infiltrates that are present in the periphery. And if you're saying what is this blue spot around, that's the nucleus related to the muscle fiber, right? But these multiple blue spots are the neutrophilic and the immune system attack which is present in this particular disorder. So coming back to the histopathology data, I said there would be terms like perifascicular atrophy, perifascicular inflammation that would be described, and this would be in contrast to polymyositis. Obviously, you can pick up polymyositis because there would be no skin manifestations present, but over and above that, even the histopathological findings, they would mainly talk about endomyosial inflammation and perifascicular. If you remember, at least at the moment for dermatomyositis, half the job is done, because if you do not encounter it in a question and you do not encounter dermat findings described, but is mainly focusing on CPK-MM elevation with a symmetrical proximal muscle involvement more than distal involvement, then you have to think in terms of polymyositis. Now, focusing on polymyositis, the incidence would be more in females as compared to males, as is the traditional information. The proximal muscle involvement will be more as compared to the distal muscle involvement in these patients. And once you get this data right, then you need to remember the histopathological finding in this particular case, which I've reiterated a couple of times, which is going to be mainly with respect to endomyosial inflammation. Now, we have to compare all these findings with that of anti-synthetase syndrome, where a very peculiar pickup word in the MCQ will be given, that is mechanics hands. Just like a car mechanics hands would have cracks present, that's because of contact with engine oil and abrasives and all the hard work that they're doing. You will notice that anti-synthetase syndrome also, the lady would be having cracks on her hands, which would be referred to as mechanics hands. That's a very good pickup point. And the antibody which is present in this condition would be called as anti-amino-acyl tRNA synthase. In fact, one of the classes of antibodies which is anti-amino-acyl tRNA synthase is anti-Jo1 antibody, short and sweet, JO-1. I'll write the name in a while, but anti-Jo1 antibody will be described for anti-synthetase syndrome. And at this moment, I also want to bring to your attention that sometimes in patients of anti-synthetase syndrome, some features of polymyositis can also be described. So, I mean, do not be surprised if they do mention about that symmetrical muscle involvement for this particular case. In fact, the data I can mention like this, the question will again open up by describing a female patient. He will again say proximal muscle involvement or proximal muscle weakness more as compared to distal muscle weakness, and the symmetry will still be preserved. I mean, if there is weakness with respect to muscles of the left hip joint, then the weakness would be with respect to muscles of the right hip joint as well. And in these patients as well, the CPK-MM values would be elevated. The rise of CPK-MM in this condition may not be as gross as what is seen in dermatomyositis or polymyositis, but yep, I mean, the rise is very much there. And then these patients would be exhibiting a rash as well. This rash is what I'm saying. This could be, mistaken for the rash of dermatomyositis as well. So all I can say is polymyositis and dermatomyositis findings could be present even in antisynthetase syndrome as well, which is usually the reason for error. And that is why right in the beginning for antisynthetase syndrome, I had mentioned regarding the term mechanics hands, which I did not describe for the description of dermatomyositis. I repeat the fact, rash and biopsy findings that are present in antisynthetase syndrome are tend to be shared with that of dermatomyositis. I mean, both diseases could be having rash, both diseases could be having identical muscle biopsy findings. So therefore, what you need to remember is mechanics hands, which is a good hack to, get the question right on clinical grounds. Though antibody name will also be given, and the name of the antibody is again what I've stated right in the beginning, anti-Jovan antibody, which is a class of amino acyl tRNA synthetase directed against amino acyl tRNA synthetase. Interstitial lung disease can be present even in antisynthetase syndrome. So in the question, he can mention spirometric findings like residual volume being lesser, total lung capacity being lesser. And one of the very good ways to identify interstitial lung disease over and above spirometry is DLCO, that is diffusion capacity of the lung for carbon monoxide. Over and above this, Raynaud's phenomenon can be encountered in these patients. Even joints can be involved. The type of arthritis that is seen here, I mean, the large joints can be involved. Traditionally, we are reading about muscle involvement, but this is first time that I'm incorporating joint involvement, and that to a non-erosive arthritis. Traditionally, you read about non-erosive arthritis with rheumatic, the one that is seen with bachon mein na, that group A beta hemolytic streptococcus ke saath mein, that rheumatic migratory polyarthritis in majority of cases is non-erosive arthritis. And then comes the keyword, which I've already said earlier. I'm repeating once again, that would be mechanics hands, which would be described in this patient. That would be an image-based question where cracks on the tips of the fingers would be noticed, just like cracks on the tip of a finger can be seen in a patient who's, let me say, a car mechanic due to contact of hand with abrasives and engine oil and grease, and while changing tires, there are bound to be cuts on the hands. A fever can be present in any rheumatoid disorder, but is a predominant low-grade fever for a long duration, could be persisting in patients of antisynthetase syndrome. So the main crux of the discussion is that for per se for antisynthetase syndrome, what you need to remember is one, this name of the antibody, and second is the name of mechanics hands per se, and that should do the job as far as solving questions with respect to dermatomyositis versus polymyositis and antisynthetase syndrome is concerned. As far as the risk of malignancy is concerned, I've already explained to you, but I'll just say that once again, that risk of malignancy, like a woman of dermatomyositis would be having increased risk of ovarian cancer. Even in polymyositis, that risk would be present, but would be lesser as compared to that in dermatomyositis. Now, a few bits more towards the end of this video. One would be Cogan syndrome. Cogan syndrome would be having one eye involvement, that is to be remembered as interstitial keratitis. And why that's important is because in Behçet syndrome, I'll be describing uveitis, I'll be talking about retinitis and hypopyon, that is pus in the anterior chamber of the eye. So Behçet's disease, I repeat again, has either anterior or posterior uveitis, but Cogan syndrome will mention regarding interstitial keratitis. Then also there would be presence of vestibulo-auditory symptoms. And the third thing that is encountered in Cogan syndrome, apart from eye involvement and the vestibulo-auditory symptoms, would be presence of aortic involvement. In fact, that's the cardiovascular association that they would like to ask for this particular topic, and the cardiovascular association is aortitis, and usually the valve that is involved in this case would be the aortic valve. I mean, if ascending aorta is involved, then aortic valve involvement can also be seen in Cogan syndrome, but there would be no cardiac valvular involvement in Behçet's disease. Behçet's disease would also be written as Silk Route disease, because most of the time he'll describe a patient who has come to India on medical tourism. He can describe a patient from Syria or an Arabic patient, a patient coming from Philistine, from Palestine. I mean, countries which are now involved in civil war and like the medical facilities are in a bad shape. So there might be rich people from there can be flying down to India to get medical care, and therefore Silk Route disease is usually a description of an Arab patient, and he'll begin by describing oral ulcers. Now, when you read oral ulcers, you obviously will think in terms of, because oral aphthous ulcers on recurrent basis are even found in SLE. So you will be, tempted to think in terms of lupus, but at the same time, there would be some additional information that would be given, and that additional information would be in the form of genital ulcers. So this particular case that I'll be describing, that is Silk Route disease, is a patient on medical tourism who will be having crops of aphthous ulcers. I mean, like, multiple aphthous ulcers in whole of her oral cavity, and few of them are like, even if they resolve, the new ones will develop in their place. So this patient is telling you that, sir, all around the ear I have multiple aphthous ulcer in my mouth, and then she could be having any two from the four features that I next mentioned before you for diagnosis of Behçet's. Though the shortcut that we use is oculogenital syndrome, and I've already given you the hint that this lady would be having ulcers, genital ulcers, that is aphthous ulcers on the genitals. And I mean, make no mistake, Behçet's can occur with respect to even males as well. And if it will be males, then the ulcers would be occurring on the scrotum. So by genital ulcers, initially you might be getting an impression that, okay, I mean, this could be an STD as well. But then STD would, especially on a female patient, would not cause an, in a male patient, I mean, female, it can cause an ulcer on the vulva. But STDs in a male patient would be causing an ulcer on the glans penis or on the shaft of the penis and not on the scrotum per se. So scrotal ulcers is what you read with respect to Behçet's, and then the involvement with vulva is very much there. So the main point is, in SLE, you will read about oral ulcers, but you will not read about genital ulcers. And additional features which could be present in these patients is the eye involvement. The eye involvement will usually be described as hypopion, that is pus in the anterior chamber of the eye. So there could be red eye, there could be uveitis, and the bad news is even retinitis could be present, that is posterior uveitis, and then even retinitis can be found in these patients. The next feature, which is of importance and diagnostic, is called as pathergy phenomenon. Now, what you need to understand is pathergy phenomenon is type 4 hypersensitivity reaction. And this type 4 hypersensitivity reaction, how would you elicit it? For eliciting pathergy phenomenon, you will be using a 20 gauge needle and you will be gently making a prick on the forearm. Simply, you're not injecting anything into the skin. You're not injecting anything into the skin. Unlike in Mantoux test or Lapromain test, where you're injecting, like in Mantoux test, you do injection of PPD, that is purified protein derivative, into the forearm, and then you evaluate after 48 hours. Here you are making a gentle prick with a 20 gauge needle in the forearm of the patient, and after 24 to 48 hours, when you will be re-evaluating the forearm, you will be able to see a sterile pustule. I mean, that's the peculiarity, guys. The peculiarity is you are just making a small prick in the forearm of a patient with a 20 gauge needle, and there is a sterile pustule that is developing. So that is pathergy phenomenon. It's also written as pathergy test. It's not the most important criteria for diagnosis. You can see the most important criteria for diagnosis of this condition would be oral ulcers, and along with the oral ulcers, at least two of the following findings would be present. And the fourth finding, which is to be remembered, is skin manifestations. Skin manifestations could be in the form of erythema nodosum. Erythema nodosum, the image that I've shown in sarcoidosis in the earlier part of the video, the same thing would be valid. Purplish nodules on the shin of a patient. Apart from erythema nodosum, even folliculitis or pseudofolliculitis could be developing, but the main skin manifestation that we see here is erythema nodosum, and from the four of these, at least two should be present along with oral ulcers to make a diagnosis of Behçet's disease. Then they can incorporate a bit of pharmacology here, and they can ask you regarding the drugs which are useful. So especially if it is oral ulcers, we'll initially be using topical steroids. In fact, the mainstay of treatment will be topical steroids only, but then they might also like to ask regarding a phosphodiesterase 4 inhibitor, that is apremilast. And apremilast, it is a phosphodiesterase 4 inhibitor. It tends to reduce the inflammation and helps in curing of the oral aphthous ulcers. And for the eye manifestation in these patients, we might be comfortable using azathioprine. So traditionally, whenever we are reading about oral ulcers, we use topical steroids. Even if it is genital ulcers, initially it is topical steroids only. But then they might love to ask about the eye manifestation of Behçet's disease, that is Silk Road disease, where an Arab patient, a patient from Iraq or Iran or China or Mongolia, and medical tourism in India, as you know, is booming. So, I mean, this is, I would say, the best decade to be a doctor, because post-COVID people have, at least in major cities, people have realized that health is a luxury that they need to spend money upon. Just like earlier, the concept was, okay, we need to go out and have, holiday is something that I deserve. Now it is good healthcare is what I deserve. So people are ready to pay money. It's just that, you just need to learn these skills. Whatever we are discussing today is a part of your building up to that level where you are able to provide good services to your patient, and then automatically the financial health of yours is ensured. So anyway, I thought I should speak about it, because we usually as doctors don't talk about financial health. We talk about everything from mental health to physical health. But then by learning all this, you're trying to build up to your financial health itself. Coming to the end of this video, I know you are tired, so we'll just take up two more terms, that is mixed connective tissue disorder and overlap syndrome. Rheumat is all about antibodies, guys. So the main test to be remembered for mixed connective tissue disorder is U1-RNP, that is ribonucleoprotein antibody, and that is not to be mixed up with ribosomal P antibody, that is responsible for neuropsychiatric manifestations of SLE that I've explained. And then at least two of the following. What I mean by two of the following is the following rheumatic disorders, any of the two could be present. Like for example, it could be SLE, it could be systemic sclerosis, that is scleroderma, then rheumatoid arthritis, and then even polymyositis. So the main point is it is antibody with any two of the following. So don't be surprised if you read a question where there is a description given for Malar rash as well as Raynaud's phenomenon, and then also talks about muscle weakness in an individual. And now is a new term that is called as overlap syndrome. Overlap syndrome, basically I would rate it as the most important data for this particular slide, and from perspective of any set, that is polymyositis and dermatomyositis. If it is occurring with combination with any connective tissue disorder, then it is referred to as overlap syndrome. Please pay attention to the fact that I did mention polymyositis earlier also, but there I was talking about its association with SLE, but there must be an antibody present, that is U1-RNP. If that antibody is not described, then he just gives any connective tissue disorder like SLE or scleroderma or whatever, and mentions regarding polymyositis or dermatomyositis clinical findings or histopathologicals or muscle biopsy findings, then you will answer this as overlap syndrome. So these are the details that I want you to remember for this topic. Thank you so much for hearing me out, and keep the pressure on, guys. Keep this learning process on a daily basis. Try to do one topic every single day. It's like eating the frog. You just need to put pressure on your mind, and your mind adapts. Our mind has a great capability. If you're reaching up to this much area in the app, if you're reaching to this segment of the app, that you are reaching up to rheumat, I'm very sure that you have done cardiology, neurology by this particular point of time. So you are doing perfectly fine. And in case you're doing rheumat initially, no issues, but still I would personally prefer that, from the exam perspective, because majority of questions are those of cardio and neuro and endocrinology and respi, so that sequence in the app should be the one that should be respected. But great if you're reading through this, even if you've come to this topic right away and you've come this far, I acknowledge your mental strength. I acknowledge your dedication towards your field. And as I said, you're doing it for yourself, for your financial growth. You're doing it for your mental, building up your mental strength, and that would automatically ensure the financial health of yours as well. So thank you so much, and God bless you.